Good evening, everyone. A warm welcome to one and all for this Vivaadham webinar series, episode 10. This is an effort of and brainchild of our president, Sampath Kumari Madam. The whole point of this webinar's Vivaadham series is to take one particular topic in obstetrics, gynecology, fertility, fetal medicine, gynec endoscopy, urogynecology, in any aspects or subspecialty of obstetrics and gynecology. And there may be two different schools of thought. So we are just going to highlight the important aspects of this different thoughts and with call upon people from different parts of the country and with a moderator who will give us an overview. So it's going to be more of a practical session, clinical session, or with evidence and experience. So myself, I'm Dr. Karpagambal Sairam, consultant obstetrician gynecologist and fertility specialist, and an executive committee member of OXY. So myself, along with my coordinator, Dr. Vijaya Madam, who is HOD and professor of VSA Medical College and Hospital, former director of IOG. Madam was a very vibrant past president of OXY and special interest in high-risk pregnancy, infertility, and laparoscopic surgery. So both of us, along with the entire OXY team, President Dr. Sampath Kumari, Secretary Dr. Meena Mahalingam, and the entire team, we welcome you to this Vivaadham webinar series, episode 10. Today's topic is scope of third trimester scan. So the whole point here is we are mainly focusing on the growth, the Doppler, the Leica, maybe the placental morphology. But many times we see a disclaimer in all the reports saying that detailed fetal survey not done due to fetal position, and sometimes even the body habit as the patients can have a thick layer of abdominal wall, so it might be difficult to view the anatomy. So the whole point of this webinar has been to say what things are very, very important in third trimester scan. Can others please mute yourself, please? So what are the main point? Apart from one aspect is focusing on growth and Doppler, identifying following up of early onset FGRs and identifying late onset FGRs. But at the same time, can we overlook other things like evolving anomalies and any other problems that can happen in the third trimester? So we have two speakers who are going to talk, one about focus on growth, the other is going to talk about beyond growth, what all is mandatory to be seen in the third trimester scan. So, and we can't just like write a disclaimer and say that, oh, this is what it is and it's not, we can save our skin. But at the same time, even though we write a disclaimer like that, and it's very important to look at things, what has to be seen in the third trimester. Dr. Meena, she's our very fond secretary of OXY. She's a consultant, professor at IOG now. She's transferred from Chengalpattu to IOG. Very happy to associate with Meena for many, many years. She's going to say the OXY prayer.
Thank you, Karpagam. So on behalf of OXY, our President Sampath Kumari ma'am, who is in another CME, I would like to welcome each and everyone. Vijaya Madam and Dr. Karpagambal Sairam have been coordinating this Vivaadham webinar series so well. And to start with, we'll start with the prayer. Thank you, God. In humility we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you, Karpagam. Over to you. And I request each and every participant to vote for Dr. Sampath Kumari Madam, who is contesting for President election next year, that is this year, between August 1 to 10. So kindly cast your valuable vote for Sampath Kumari ma'am. Over to Karpagam to start with the proceedings.
Thank you, Dr. Meena.
So you were on the complaint.
Others, please mute yourself.
Radhika has not been allowed to play.
Shripriya, matavangala mute pannidinga. Yeah. Thank you, ma. Thank you. Next slide. Sampath Kumari Madam is unable to join. So Madam is our President of OXY. And now I'm going to welcome Dr. Vaishnavi Jathana. She's a clinical fellow of fetal medicine at Bangalore Fetal Medicine Center.
साइन पर जा रहे हैं
Former junior consultant
Dr.
postgraduate
Saranya,
medical
kindly
both.
mute yourself.
Yeah, others please mute. And she's a recipient of Dr. Padma Rao Award for Best Outgoing Resident in Obstetric Gynecology at Manipal. And she's from KMC Bangalore. So Dr. Vaishnavi is going to talk about the focus on growth. So what are to be seen and how are we going to identify growth abnormalities in a third trimester scan? Over to you, Dr. Vaishnavi. You can share your screen, ma'am. Yeah.
Happy to welcome Vaishnavi, our own alumni. I'm also from KMC Bangalore.
Yeah, Meena is from KMC.
From KMC Bangalore, yeah.
Bangalore. Yeah, we can make it full screen. Yeah, go ahead, ma'am.
My lord.
Dr. Vaishnavi, ma'am, you are
Can
muted.
everyone be
Dr.
muted?
Vaishnavi,
Please
you are
mute
muted.
everyone.
Good evening, ma'am. Am I audible now?
Yes, you're audible.
Yeah, I'm thankful to Dr. Karpagambal ma'am, the entire team of Oxy, and Dr. Pratima ma'am for this opportunity. So I'll be talking on the third trimester scan with a focus on growth. So this was the antenatal pyramid of antenatal. This was the pyramid of antenatal care, which was traditionally followed, and this pyramid was based on the ideas that complications usually arise late in pregnancy. Because of this belief, the medical visits of a pregnant lady used to increase in frequency as her due date used to approach. This particular model was also called the top heavy pyramid. But it was in the year 2011 that Professor Kypros Nicolaides introduced the concept of inverting this pyramid of antenatal care, wherein he advised that the most intensive assessment should happen at the end of the first trimester instead of waiting till the end of the pregnancy to do it. And it was because of this approach that the goal of third trimester scan
Are we
changed.
able to hear? There is some disturbance.
Is it okay now, ma'am?
1 second. Others, please mute yourself, please. Shripriya, mute
Is
everyone.
everyone able to see the screen? I'm not.
Yeah.
We are able to see your screen.
Is it okay, ma'am? Should I share it
We can
again?
able to see the chat. We can able to see the slides, ma'am, and voice also clear only.
Yes. We are
Chinmay,
able to
ma'am,
do it.
you have any problem?
Chinmay, are you able to see, ma?
I think ma'am's internet is very low.
Yeah, I'm just leaving and rejoining because I'm not able to see her screen.
Yeah. Okay, you can just log out and rejoin.
Let me know, ma'am, if I can continue, ma'am.
You can go ahead, ma.
Yes, ma'am.
Yeah, you can go ahead.
So with this, the goal of the third trimester scan changed from being a scan of late diagnosis and crisis management to a scan which was followed by an early prediction and prevention done in the first trimester itself. So the third trimester scan carries a wide scope where we can determine the fetal viability and presentation. We can assess the fetal anatomy. We can assess the fetal growth, amniotic fluid, and fetoplacental Doppler. And we can also assess the placental location and other characteristics of the placenta. So we'll be focusing on the fetal growth for the next 15-20 minutes. And apart from the third trimester being a routine scan, it may also be indicated to do a scan in the third trimester when the patient presents to us with antepartum bleeding, when she has reduced fetal movements, when she has preterm premature rupture of membranes, if there are any suspected abnormalities of fetal growth, and as a guide to the procedures like external cephalic version. We may also use this third trimester scan to assess the gestational age and to exclude a suspected multiple pregnancy, but this is done only if the mother has not had any ultrasound examination before the third trimester in her pregnancy. So when we look at determining the gestational age in the third trimester, we do it with the help of a combination of head circumference and the femur, or with the head circumference alone. But we have a couple of limitations while doing this. This is not very accurate in determining the gestational age, and we have a variation of about 15 days, or rather a range of 7 to 21 days. The head biometry may become difficult to measure accurately, especially when the head goes deeper in the maternal pelvis. And we have also tried using formulas that involve the transcerebellar diameters, which is said to be spared even in growth abnormalities, but this also has shown to have a lower prediction. So when even till now, a good first trimester CRL is the most accurate parameter that we can have to determine the gestational age, which again emphasizes on having a good first trimester CRL or a scan done. But if it has to be determined in the third trimester, a combination of head circumference and FL remains the mainstay. The abdominal circumference is not included in this gestational age calculation because being susceptible to growth abnormalities, it increases the margin of error to about 18 to 35 days when estimating the age. So now what gestational age can we say is optimal to do a third trimester scan? It is based upon having a balance between the optimal visibility of the fetal anatomy and the optimal accuracy of the fetal growth assessment. So when we look at it as a whole, the gestational age of a third trimester scan depends upon what objective are we having while examining or performing this examination. Traditionally, it is scheduled between 32 to 34 weeks of gestation. So the SWOG guideline of the third trimester scan tells us that the timing of the third trimester scan, if indicated between 32 to 36 weeks, is decided based on the individual maternal and fetal characteristics, the level of risk of the pregnancy, the local objectives, and the resources. And what is the optimal gestational age to assess growth? So if we look at growth alone, then a scan done at 36 weeks or more has proven to be more effective to determine a small for gestational age or a growth restricted fetus in comparison to a scan done at an earlier gestation, let's say 32 to 34 weeks. So the same thing has been again highlighted in these work guidelines where they say that the screening of SGA or FGR in the general population is more accurate when the examination is performed at 36 weeks rather than 32 weeks. So the third trimester scan is essentially based on acquisition of the basic biometry such as the head circumference AC, the abdominal circumference and the femur length. And it is the correct and optimal acquisition of these planes that helps us in getting a good result, a more optimal result that helps us in getting a good outcome for the mother and the baby. So the head circumference must be measured in a transverse or the axial plane with the the cerebral hemispheres being visualized equally with the midline falx in the middle, the calipers being placed from the outer to outer end for measurement, and the plane essentially is a transventricular or a transthalamic plane. The assessment of abdominal circumference is done again by the means of an axial section at the level of stomach with a single rib surrounding the section with the spine essentially at the 3 o'clock or the 9 o'clock position with the umbilical vein entering into the abdomen visualized. And the femur length is visualized as the measurement between the diaphyses across the two ends without the epiphysis being measured and the spurs of the bone being excluded. So our third trimester scan is as good as our acquisition of these planes. After acquiring these planes, we plot each of these measurements along with the measurement of the estimated fetal weight on a growth chart, and we also calculate the centiles. So these charts help us in determining something called as the fetal growth velocity, which is nothing but the growth trajectory. So it must be understood that the growth of the fetus is a dynamic process and it is not something which can be assessed at a particular point of time. So even now we receive reports in which the growth has been described in terms of weeks of gestation, and this practice must be stopped, as in we must not change the gestational age each time we assess the fetal growth. The gestational age remains fixed from the first trimester, and it is the growth that deviates from the different across the different examinations. So this growth trajectory or the growth velocity is determined with the help of a growth chart which is a longitudinal growth chart depicting the gestational age along the x-axis and the measurement in millimeters or the weight in grams along the y-axis. So Our target is to assess deviation from normal in these growth velocity charts. And this helps us in doing something which is an individualized growth assessment. So these growth charts usually have a range between the 5th centile, which is indicated by the lower line, and the 95th centile, which is the upper line. And we expect the growth to stay between these two lines and not just the fall from the 5th centile, but it is a fall of more than 50% in the abdominal circumference and the effective fetal weight. That is also considered to be a parameter or a marker of growth restriction. So we have a couple of growth charts that we use to assess fetal growth, Hadlock being the most common, but we also have our population specific charts. Each of them are available online for free use. We also have a lot of charts pre-installed in our softwares for use, and 10th to 90th centile is considered appropriate fetal weight, and the margins, the lines drawn on the charts are essentially the 5th to 95th centile. Moving on to the assessment of amniotic fluid volume in the third trimester, it is done with the help of either a deepest vertical pocket or the amniotic fluid index. We call oligohydramnios as a deepest vertical pocket of less than 2 centimeters, less than or equal to, and AFI being less than 5 centimeters. Polyhydramnios is a deepest vertical pocket of more than equal to 8 centimeters and an AFI more than 25 centimeters, which is further subclassified into a mild, moderate, and a severe type. Mild being 25 to 30, moderate being 30 to 35, and severe being more than 35. So it is said that AFI is preferable in assessing polyhydramnios, while DVP is the modality which is preferred while assessing oligohydramnios. DVP helps us to cut down an unnecessary intervention that would have been done if we take an AFI measurement to assess less lichar or oligohydramnios. So we can have oligohydramnios due to growth restriction, due to rupture of membranes, due to anomalies like any pathologies of the fetal urinary system, or because of maternal factors like preeclampsia or any other pathologies that cause placental dysfunction. While polyhydramnios is most commonly due to maternal diabetes, may also be due to fetal abnormalities, in particular the GI, CNS, and cardiac abnormalities, may be in association with placental tumors, fetal infections, chromosomal and genetic abnormalities, but in 50 to 60% of the cases, it is idiopathic. Coming to the third aspect that we assess in respect to growth in the third trimester, that is the Dopplers. So we have essentially the uterine arteries, that is the maternal component, the umbilical and the middle cerebral arteries, the arteries in the fetus, and the ductus venosus and the umbilical veins. So these 5 vessels are essentially the vessels that are used to assess the blood flows in the fetus in a third trimester scan. Umbilical vein has a very limited use. So it essentially comes down to the uterine, umbilical, middle cerebral, and the ductus venosus. So these are to identify the uteroplacental insufficiency, to assess fetal cardiovascular response and adaptation to hypoxemia, and to differentiate between early and late onset growth restriction. So the umbilical artery, which is traditionally measured in a free loop, as the fetal end would have a higher resistance and the placental end of the umbilical artery would have a lower resistance. So to keep it uniform and simple for all, we usually measure it in the free loop. So as and when we see a growth restricted baby, the PI starts to increase and subsequently we come across an absent or a reversed end diastolic flow in the umbilical artery, which is evident here. Then the second vessel is the middle cerebral artery, which is assessed at the level of the circle of Willis, just below the plane where we acquired the head circumference. And this vessel gives us a picture of the blood supply in the brain, and a growth restricted baby would likely show the pattern of cerebral redistribution, thereby decreasing the pulsatility index and increasing the flow to the middle cerebral artery. And the ductus venosus is a vessel that is visualized in the fetal abdomen, which is given off from the umbilical vein and subsequently drains into the IVC and then the right atrium. And again, this is an important vessel which helps us to determine the timing of delivery in the growth restricted babies. So we see changes in the umbilical and the MCA early on in the growth restricted babies, while the changes in the ductus venosus are seen late. So coming now to the role of the third trimester scan in detecting and managing SGA or FGR. So SGA and FGR, the small for gestational babies are the babies that are less than 10 centile in size for their gestational age. This is described in terms of the abdominal circumference or in the terms of estimated fetal weight. Whereas a growth restricted baby is a baby that fails to reach its growth potential. So, SGA babies, although small, are not at an increased risk of perinatal morbidity and mortality, whereas growth restricted fetuses may be more than 10 centile in terms of measurements, but are at a higher risk of having an adverse outcome. So, SGA babies are healthy, constitutionally small fetuses. This group is approximately 50 to 70% of the SGA group. And there are some fetuses which are pathologically small as well. But in the growth restricted babies, we may have fetuses with SGA that may be only 10%, and the other fetuses may not even be 10, may not even be small in terms of measurements, but they might have falling percentiles and an abnormal Doppler. So it is this group that is essential for us to identify and manage appropriately. So how do we define growth restriction? Again, it is either with the help of AC or EFW, that is less than third centile, which will let us directly label them as a growth restricted fetus, or we have a baby in which the abdomen AC and the EFW is less than the 10th centile with evidence of placental dysfunction, which is either by the means of an abnormal uterine artery Doppler, wherein the mean PI is more than 95th centile, or an umbilical artery Doppler, where the PI is more than 95th centile, or there is absence or reversal in the flow. So why is it so essential to differentiate? So after detecting SGA, it is equally essential to differentiate between SGA and FGR, because SGA babies will have a normal and perinatal and long-term outcome. The risk of fetal demise in SGA is extremely low. These babies will not show any signs of adaptation, and this most likely is going to be a constitutional variant. Whereas the growth restricted babies carry a poor perinatal and long-term outcome. They have an increased risk of intrauterine demise. These are the babies that will show the signs of fetal adaptation, and this is essentially a pathological entity. So after differentiating growth restriction from a small for gestational age, it becomes essential to identify if it is an early onset FGR or a late onset FGR. So again, this distinction is based on the ultrasound criteria, that would be AC or EFW less than third centile along with abnormality in the umbilical artery, or AC or EFW less than 10 centile combined with a uterine artery PI of more than 95th or an umbilical artery PI of more than 95th centile. Whereas the late FGR would be the one that would have occurred after 32 weeks, and this would be AC or EFW less than third centile and at least 2 out of these 3. That is AC or EFW less than 10th, AC or EFW falling by 2 quartiles, like from 75th centile to 25th centile, would make it qualify for late onset FGR. And a CP ratio of less than 5th centile for the gestational age, or an umbilical artery PI of more than 95th centile. So this is an illustration by Professor Grathakos's guideline that was given in the year 2014. So the early onset FGR is a disease with increased impedance in the placenta, subsequently leading to hypoxia in the baby. So early onset FGR will be evidenced by an increased uterine artery PI in the beginning, and subsequently changes in the umbilical artery PI will be seen, and at the end there will be changes in the ductus venosus, and after that we'll see changes in the biophysical profile and the CTG. Whereas the late onset FGR is more of a disease of reduced placental reserve. So we will not be seeing the changes in the umbilical artery per se, but we will start seeing changes in the CPR and the MCA PI, and subsequently changes in the CTG. So early FGR babies are the chronically starved babies So although they are easy to detect but difficult to manage and probably with a worse outcome, but the late onset FGR, though mild, they are adequately fed babies which are probably then starved suddenly. So the risk of demise, sudden demise, is more probably with the late onset FGR. So, in the same guideline given by Professor Gratakos, they also give us stages of the FGR and subsequent guidelines for monitoring those pregnancy. So, stage 1 is the one where the placental insufficiency is mild and the end diastolic flow in the umbilical artery stays positive. So, these have to be monitored weekly, and the target of delivering them is by 37 weeks. Stage 2 is when this placental insufficiency becomes severe and we start seeing absence of end diastolic flow in the umbilical artery. We try to monitor them bi-weekly and deliver them by 34 weeks. The third stage is when the severity increases, there's low suspicion of fetal acidosis, and here we'll have the umbilical artery with a reversal of end diastolic flow and an increased PI in the ductus venosus. These have to be monitored every 1 to 2 days, every day preferably, and must be delivered by 30 weeks. And the stage 4 is when there are highly suspicious of having fetal acidosis. These are quite premorbid, can be associated with fetal demise at any time, and they will have changes in the ductus venosus, decelerations on the CTG, and must be monitored every 12 hours and must be delivered by 26 weeks if we start seeing them early. So, the role of the third trimester scan is to identify the correct point of delivering them. So, the idea is to deliver by balancing against the possible harm caused by prematurity. So, the timing of delivery must be aiming to have a baby with least hypoxia, least acidosis, and maximum lung maturity. So when we look at different gestational ages, we have different blood vessels guiding us to take decision to deliver. So when we come across 24 to 26 weeks of gestation, the management is more or less personalized. Although the neonatal units have been improving dramatically, still the prognosis of a baby as preterm as 26 weeks is bleak as of now in our country. So when we move on to a baby that is between 26 to 29 weeks, it is the ductus venosus whose abnormality must determine the decision to deliver. When the baby is between 29 to 31 weeks, 6 days, again it is the ductus venosus, an abnormality in which must determine the decision to deliver. However, after 32 weeks, it is the umbilical artery in which reversal or absence of flow must determine our decision to deliver. In addition, apart from these indications, we must consider delivery if there are spontaneous repeated decelerations, if the biophysical profile score gets altered, gets less than 4, or if there is any maternal indication to deliver. If we come to 36 to 38 weeks, an umbilical artery PI of more than 95th centile is an indication enough to deliver. And if we have a gestational age of 38 to 39 weeks, any feature suggestive of cerebral redistribution or any other features of FGR must warrant delivery. So again, in presence of a normal Doppler, we aim to deliver at about 37 to 39 weeks by the means of inducing the pregnant lady. When we have a high PI in the umbilical artery Doppler, we aim to deliver the mother by 37 weeks. If there's absence of end diastolic flow, we aim to deliver by 33 to 34 weeks after a course of antenatal corticosteroids preferably. And if there is reversal in the end diastolic flow, the delivery must be done by 30 to 32 weeks after steroids. And if there are ductus venosus changes, the delivery must be immediate as there is high risk of fetal death within 24 to 48 hours. So this was one end of the spectrum. It is equally important to assess the other end of the spectrum, that is the babies which are large for gestational age. So we identify them by the means of an abdominal circumference or estimated weight more than 90th centile. And we call macrosomia when the weight is more than 4 kgs, or in some countries it is considered to be 4.5 kgs. So it is essential to identify these fetuses as well, because they are at risk of having a prolonged labor, they are at risk of having shoulder dystocia, and they are also at a higher chance of having an operative or an instrumental delivery. So again, if we are able to identify a large for gestational age baby, we must optimize the timing of delivery. So again, as I previously mentioned, the assessment of this large for gestational age is more accurate when it is done later in the pregnancy. So 35 to 37 weeks is the preferable time. And at this time, we were able to pick about 46% of the LGA fetuses with growth more than 90th centile, and 65% of the LGA fetuses with growth more than 97th centile. This had a screen positive rate of about 10%. So to conclude, the third trimester ultrasound is essential for assessing growth in Doppler. Assessing size is not enough. We must also assess the fetal growth velocity. We must differentiate whether it is a SGA baby or a growth restricted baby based on the Dopplers. And this is essential so that we can optimize this pregnancy and choose the appropriate timing of delivery. And we also need to identify the large for gestational fetuses for an optimal perinatal outcome. So this is a summary of all the guidelines wherein they tell us at what gestation we should necessarily perform a third trimester scan and what elements we must include in the third trimester scan. That's all. Thank you.
Thank you, Dr. Vaishnavi. That was a very clear presentation about the importance of, assessing growth at what period of pregnancy, of gestation, and the importance of, each and every Doppler parameters, including the umbilical artery, even uterine artery, MCA, and also the fluid AFI. So now, thank you so much for the clear presentation. Now, I'm going to call upon Dr. Monisha. Dr. Monisha CV? Yeah. Dr. Monisha Arudalan. She is done an MBBS from Vaidehi Institute of Medical Sciences and Research Center, Bangalore, and MS in JIPMER, Pondicherry. And she is currently a fellow in fetal medicine at Mediscan Systems, Chennai, under the guidance of Dr. Suresh and Indrani Suresh and Dr. Sudarshan. Over to you, Dr. Monisha. So you're going to tell everything other than growth.
Yes.
So when the disclaimer says that, detailed fetal survey not done, so you are going to survey the baby well and tell us what to be seen and what not to be missed at all. Okay?
Yes. Good evening. I'm Dr. Monisha Adlalan, Fetal Medicine Fellow at Mediscan. I'm privileged to present today under the guidance of my mentor, Dr. Sudarshan sir, and I also thank Octa Society for this opportunity. So the topic or the objective of this presentation is third trimester obstetric scan, which is beyond growth. That is, it is to redefine our approach to the late pregnancy imaging. We consider that the fetal biometry, it is the most standard component of a third trimester scan. Often we overlook the critical markers of a fetal and the maternal safety. So today we will explore how this scan will serve as a critical final checkpoint for the fetal well-being and for the delivery planning. So this is a very comprehensive framework that constitutes a routine third trimester scan. So while the title of this presentation is Beyond Growth, so it is very essential that we establish what are the standardized pillars that we evaluate during the each session. So we begin with, again, starting with the fetal viability, and we assess the placenta, not only with its location, but also its overall morphology, the presentation, the growth, that is the parameters we measure. And we also look into the amniotic fluid. In the growth, we also look for the growth pattern. Rather than looking at a single point, we look at the trajectory rather than going into a single parameter at that in a single time. And we also assess the environment, that is the amniotic fluid volume, which is a dynamic indicator of both the placental perfusion as well as a fetal renal function. And next is the fetal Doppler, where we evaluate the umbilical and the middle cerebral arteries to detect the placental insufficiency. And finally, we also perform a late-term screening for a fetal abnormalities. Some structural issues are only become apparent or significant in this final window. So by addressing all these pillars, we give a very holistic approach for this pregnancy, which helps in as well as in the clinical management, just rather giving a just estimated fetal weight. So, one of the most frequently asked question is, when is the optimal time do you perform a third trimester scan? So, as we can see that the answer depends upon what is our primary clinical objective. See, we do at 32 weeks as well as 36 weeks. Both offer a distinct diagnostic advantages. The earlier scans at 32 weeks, we generally have a very superior acoustic window. So, because there is relatively a higher volume of like compared to a fetal size. So we can encounter a very less fetal flexion, allow for a better anatomical visualization and easy tissue penetration. This gives often a final opportunity to detect the late manifesting structural anomalies that may not be that we would have missed or yet to be evident during your target scan. The later scan, that is at 36 weeks, provides a more accurate growth assessment. It gives a better detection for a SGA or LGA detection, which improves the predictive value for the potential delivery complications. So ultimately, there's a box that is given, that is the timing should be individualized. We must decide based on the maternal and the fetal risk factors and pregnancy characteristics and depending upon the specific resources that is available. So while concluding that the 32 weeks is superior for an anatomy, whereas 36 weeks is often superior for birth planning. Coming to the very important, that is the cornerstone of late pregnancy safety, it is the placental location assessment. So we initially document the definitive placental location and its precise relationship with the internal loss. So quantify the clearance by measuring the exact distance from the leading edge of the placental edge to the internal loss. How do we follow up? If we have seen that the placenta is completely covering os in your target scan, so we reevaluate again at 28 weeks. If you just see there's a low-lying placenta, for say it is 1.5 centimeter or 1.7 centimeter away from the internal os, we always monitor this kind in the later trimester to allow for the possibility of a placental migration. So it is also says that the vaginal birth safe if the leading edge is more than 2 mm from the internal os. Between 10 to 20 mm, it is 56 to 93% successful vaginal delivery. So coming to the another important thing that we see is the placenta accreta syndrome. So we must screen for the placenta accreta syndrome, especially in a patients with a prior uterine surgeries. This assessment focuses on the 5 key flag signs that you see, sonographic signs, red flags that you see. One is the loss of clear zone. There is an absence of a normal retroplacental hypoechoic space, or there is a myometrial thickening. There is a significant thickening, significant reduction in the thickness of the uterine wall, or there is a disrupted interface between the bladder wall and the uterus, or certain placental features which are abnormal markers such as placental lacunae, bridging vessels or exophytic masses, or a hypervascularity which we can detect by Doppler. So all these help in the early detection of these signs is critical, as any women with the placenta previa and the history of cesarean sections should be managed as a potential for a placenta accreta syndrome case in a specialized center. So the prenatal ultrasound achieves a 90% of a detection rate for a placenta accreta syndrome. This allows for a multidisciplinary surgical approach, which is vital for the maternal safety. Despite all our efforts, again, the 5 to 10% of the cases remain undetected prenatally and are only identified at the time of cesarean delivery. So this highlights the necessity of maintaining a high index of suspicion, especially in presence of a placenta previa. One of the most predictive marker is the interrupted bladder wall interface. When this sign is specifically present, the post-test probability of a placenta accreta syndrome increases from the baseline of 21% to a staggering to 85%. Next is a vasa previa. So this condition is where the fetal vessels run through the membranes unprotected by the umbilical cord or the placenta across the internal cervical os. So this clinical stakes are very, very important, where we can see that the vasa previa remains undiagnosed prenatally. It carries a devastating of 56% of perinatal mortality rate due to its immediate fetal exacerbation upon rupture of membranes. Conversely, with a correct prenatal diagnosis and a planned cesarean delivery, a survival rate reaches 100%. This transformation from a fatal outcome to a perfect survival rate is the ultimate justification for the meticulous third trimester screening. The transvaginal ultrasound with the color Doppler becomes a gold standard, which provides 100% sensitivity and 99% specificity in identifying the condition. It is also to be remembered that if you have suspected a vasa previa earlier in pregnancy, there is a 23% resolution rate between the second and third trimester. That is why a definitive third trimester reassessment is mandatory. Coming to the breech presentation, we know that it takes approximately 40 scans to detect one previously undiagnosed breech. Means, while that seemed to be very high, this proactive approach reduces the emergency cesarean section rates by 0.7% and unplanned vaginal delivery breech deliveries by 1%. Implementing universal screening leads to a 71% reduction in the undiagnosed breech presentation at the time of delivery, thereby offering a long-term safety by reducing the low Apgar scores, hypoxic ischemia encephalopathy, and overall perinatal mortality. Now coming to the very, very important cornerstone of detecting the anomalies, third trimester anomalies. Either it may be a missed anomaly in the target scan, a new diagnosis, or it can be an evolving anomaly. So we'll be discussing the standardized anomalies. How do you systematic approach in identifying these abnormalities? So moving forward, we must address a very common misconception that all structural abnormalities are identified in your target scan. This slide highlights why we have to continue our vigilant anatomical survey into a later pregnancy. So according to this data that is published by the Durka et al. BJOG 2021, we could see that the incidence of the fetal abnormalities at the routine ultrasound at 35 to 37 weeks accounts to approximately 2%. Though this number seems to be very small, the breakdown of this will have important analysis where we can see that 68% of these anomalies were already identified during the first and second trimesters, whereas crucially 25% of these abnormalities are detected for the first time during the third trimester scan. So this often includes the late evolving conditions that are like CNS anomalies or a gastrointestinal obstructions or renal issues that becomes only apparent when the baby becomes matures or it becomes bigger. Despite all our efforts, about 7% are only identified for the first time in the postnatal period. So this is the same paper where they have prospectively studied on 52,400 singletons at 35 to 37 weeks. Now, statistically, approximately 3.7 per 1,000 pregnancies will have an anomaly that is diagnosed for the first time in the third trimester. So if we look at the distribution of this late diagnosed cases, three systems stands out. One is a urogenital system, which accounts for 63%, which is a more common category, which frequently involving conditions like hydronephrosis or other renal anomalies. Interestingly, all the 60% of renal anomalies are actually detected during their third trimester scan. CNS anomalies accounts to another 21%. As we know that the central nervous system continues to develop throughout the pregnancy. This window is critical for identifying all the late developing conditions such as ventriculomegaly, cortical malformations that may have appeared normal during your target scan. And last is the cardiac defects that accounts to 16%. So while many major heart defects are caught early, but progressive conditions like a coarctation of aorta or specific valve abnormalities may only manifest or become hemodynamically significant only in these final weeks. So this is from the guidelines of 2024, how we systematically go ahead in a third trimester. So we start with the head of the fetus. So we start with the size and head. So we evaluate the overall counter, the symmetry of the skull, a significant deviation in size, such as a microcephaly, where you can see that the head circumference is less than the 3 standard deviation from the mean, or there's a and we also look into certain abnormal head shapes like a scaphocephaly or dolichocephaly, or we also look into a critical check for craniosynostosis, which is characterized by the premature fusion of cranial sutures. Certain complex malformations, we have to be vigilant for certain dysmorphic features, including plagocephaly, brachycephaly, trigocephaly, and clover leaf, which is a characteristic or often associated with the severe skeletal dysplasias. Now, coming to after the head, we go into the brain. As we know that third trimester itself is a very dynamic period for a neurodevelopment, and certain pathologies only become evident as the brain increases in complexity. Our neurosonographic checklist includes, first we start with the symmetry of the hemispheres. We look for the symmetry of the hemispheres. We verify the midline structures and ensure that the symmetry of cerebral hemispheres. Any shift or gross asymmetry may indicate a space occupying lesions or a developmental defects. Then next we look into the lateral ventricles. We measure the width of the lateral ventricles. It is very, very important that even if you have established a normal width of the lateral ventricle in your target scan, we can find that late onset ventriculomegaly is a very significant finding, and that requires a search for the obstructive causes or other associated anomalies. We should also assess the texture of the cerebral cortex and the parenchyma. For any other anechoic structure, there we can see this is a vein of Galen malformation, the video that is playing. So it's where you can see intracranial anechoic or hyperechoic areas, which could be an hemorrhage, calcification, or cystic malformations. Perhaps the most critical beyond growth check in third trimester is the assessment of this cortical sulcation patterns. So as we can see, there's a ventriculomegaly in this picture depicted. This is a vein of Galen malformation, polymicrogyria, and there's an intracranial hemorrhage that is demonstrated here. Now we go to a very important part, that is the heart. Though we would have done in a target scan, we always assess again the situs, the heart size, the symmetry, along with the 4-chamber view, the outflow tracts, and the 3-vessel views and the tracheal views. We also calculate the cardiothoracic circumference ratio, a normal cardiothoracic ratio of 0.45 and should not be greater than 0.5. And it is very, very important that we should know that there is a physiological mild asymmetry of the the ventricles. The right ventricle is slightly larger than the left, which is a physiological. Similarly, that we see in a great arteries where the pulmonary arteries are slightly larger than the aorta. This late gestation, it is very important or identifying progressive conditions such as a progressive aortic stenosis, a pulmonary stenosis, coarctation of aorta, or a rhabdomyoma that you can see in this image. So to visualize the diaphragm clearly in the both sagittal and the coronal plane becomes a very, very, very important point that we have to see in the third trimester. 20% of the CDH are detected for the first time only in the third trimester. So this underscores why we must remain vigilant even if the mid-trimester scan, which was reported normal. So late onset CDH can drastically change the required level of the NICU care at birth. And we also assess the pulmonary, that is the lungs. We look for the lung texture and the transverse view of the chest. We have to looking for any uniform echogenicity or absence of any cystic or solid masses, such as in CPAM, bronchogenic cyst, which may be progressed since the second trimester. So this is an image that is depicting. You can see there's a depicting of a congenital pulmonary AV malformation. And here you can see this video is a heart with a 4-chamber view. You can see the stomach as well as the large bowel which is herniated or to the defect from the diaphragm into the thoracic cavity. This is just to demonstrate all the views of the heart. So you can see this is the heart, large bowel, the stomach that is inside the thoracic cavity. Next important, we go into the abdomen. So we look for any fluid collection, any calcification or cystic structures that are seen within the abdominal cavity. And these findings are never considered as routine and should always warrant further investigating and to rule out the conditions like meconium peritonitis or enteric cyst. Bubble assessment, it is very, very important to remember that the bubble dilatation is actually a common phenomenon as we approach term. However, we must distinguish what is a physiological and the pathological change. As a general rule of thumb, most significant gastrointestinal pathologies are associated with a small bowel dilatation exceeding of 14 mm. So as we have already seen that the 60% of the hydronephrosis cases are detected first time during the trimester scan. Conventionally, the anterior posterior diameter, what we measure of the renal pelvis, we measure up to 7 mm is considered as the upper limit of the normal. If the anterior posterior diameter exceeds of more than 15 mm, there's a significant risk for the need for the immediate postnatal surgery. So comprehensively, we have to look into the kidneys in isolation, a complete survey which must include the ureters and even the fetal bladder. We must evaluate the bladder size, the wall thickness, and evidence of proper emptying to rule out the obstructive uropathies. So here the image depicts there's a mild pelvic ectasis, that is UTD-A1, and you can see that there's a hydronephrosis that is seen in 31 weeks, this is a normal renal pelvis. Contradictory to that, there is a dilatation where this is called UTD-A1. This is a little more larger. This is hydronephrosis, or there can be a bladder outlet obstruction that is depicted here. Now, this data is a very recent paper where this data is highlighting why the specific window is a very critical safety check for the late onset conditions. Abnormalities are noted approximately in 2% of cases. Already prior detected anomalies account to 62.5%. What we have interested is most significantly find a new onset rate is 0.8%. To put that in a clinical perspective, it is 1 out of every 130 scans where we identify a significant condition that was previously known. Only a very small margin, that is 0.4% of new abnormalities are detected only after birth, demonstrating the high sensitivity of this late-term ultrasound when done systematically. This is again just showing the distribution of the anomalies that we encounter, that as already we have discussed, hydronephrosis stands out with 320 cases, and next is the mild ventriculomegaly followed by the ventricular septal defects. Other notable detections include the ovarian cyst, duplex kidneys, and the microcephaly. And even the rarer conditions like a vein of Garland malformation appear in the later stage data. So while in lower frequency, but still identifying this prenatally is a life saving for the neonate. So to conclude, that third trimester scan is no longer only a growth scan. So what is your clinical impact? So 3.7% per thousand anomalies can be diagnosed in the third trimester. We have 90% of placenta accreta diagnostic accuracy with the ultrasound, with 100% survival for the vasa previa through the prenatal diagnosis and 71% reduction in the undiagnosed breech presentation through this universal screening. So our findings can help in categorizing into the 3 levels of clinical management, where there is a severe impairment, identifying of a life-altering anomalies later in third trimester that may lead to a late termination of pregnancy or a specialized palliative plans for the fetus, or certain which require an immediate care, like detecting conditions like a vasa previa or a placenta accreta syndrome that require delivery at a tertiary center with an integrated pediatric and the neonatal surgical unit. Then another category is where they require a postnatal follow-up, identifying common variants like a hydronephrosis to ensure a plan for the perinatal care and the long-term neurological follow-up in place before the baby is even born. So this is about the clinical impact. So growth tracks the journey, but the vigilant guards the arrival. We look beyond the numbers to ensure a safety beginning. Thank you.
Thank you, Dr. Monisha. That was a very clear presentation about all the things. I just want to ask, okay, at the end of the session, we'll have a question answer session.
Yes.
Now I request Vijaya Madam to introduce Dr. Chinmayi Ratha. Vijaya Madam?
Yeah, I'm here. And Priya, I want
Dr. Chinmayi. Dr. Chinmayi CV.
Next slide.
Yeah.
It's okay, madam. I
yeah,
think let's move on to the discussion because this is so interesting. Let's not break the flow.
we should introduce properly. That's very important for us. And please wait for a few moments. Chinmay is a very good friend of all of us, and she's a very friendly person. As you can see, her smiling and very friendly person, and very academically active. And when you think of fetal medicine, the Chinmay's name comes to us, all of us the first. That is very, very important after Dr. Suresh. Because Suresh is our godfather in Chennai. After that, we all think of Chinmay only when we are thinking of fetal medicine, any queries. And let me introduce properly Chinmayi. She is the director and lead consultant, Revolution Center of Fetal Medicine, Hyderabad, senior consultant, fetal medicine, OBGYN, KIMS, Shine Hospital, Begumpet, Hyderabad, visiting consultant in Gachibowli, Hyderabad, Ariti Hospital, and she has a center head of ICOG FM certification course and UK approved examiner India, MRCOG Part 3 examiners, peer reviewer of Jogi and Journal of Fetal Medicine, and she's got lots and lots of award, Parangi Oration Award, Mehru Hansati Award for the Best Foxy Committee Chairperson 2025 recently from ICOG Mumbai, and every year just see in 24 down prize, 23 Bakshi prize, 22 Memorial Oration Award, 21 Leadership Award, and Abdul Kalam Service Award, and 2019 is a Foxian Award, and it goes on and on. Chinmayi, who can be the expert on this debate other than Chinmayi? Welcome to Chennai. Welcome here, Chinmayi.
Thank you. Thank you so much, Vijaya madam. It is really nice to hear this kind of an introduction, but I'm really very grateful to Sampath Kumari madam and Oxy for this opportunity here. It was brilliant listening to these two youngsters who have brought about such wonderful points with regard to the third trimester scan. So as I understand, Vivaadham means we have to have 2 points of view, but they have very brilliantly brought about about the two aspects that they were given. And I really don't think there's much of a Vivaadham left here, because it's a fact that you have to check growth, and it's a fact that you have to look beyond growth also, because we don't stop at just doing one. In medical practice, we do a bit of debating to keep our critical analysis awake. But then both of you have brought forward the points, and I don't think you have refuted each other in saying that one is more important than the other. But while both are important, there are some important questions that have come up, and I think we'll address it. So just to begin, we both agree that both of you agree that growth is also important, and looking beyond growth is also important, isn't it? So Dr. Vaishnavi, you mentioned that the third trimester growth scan is very important, and you said why it was. So there is a question actually from the audience also. Dr. Jay Sheila is which is the best time to do the growth scan in high risk and low risk form? So what would be your suggestion here?
For a low risk pregnancy, I would say 36 weeks if we talk of only growth, because as I told that it better predicts and it helps us assess it better. But if it's a high risk, we must have stratified that in the first trimester itself, hopefully. And based on that, we can do an earlier assessment starting from 26 to 28 weeks itself. So if it's a
So when
high
you
risk,
say low risk and high risk, what is the risk that you're looking at?
so the most common risks that we come across is, ma'am, when the mother has an abnormal biochemistry, has an increased risk of preeclampsia or FGR, when we estimate that at the end of the first trimester screening, or if we identify an increased uterine artery PI, be it in the first trimester or the second trimester, or if there are any maternal indication, as in if she had a previously growth restricted baby, or conditions that would make us anticipate a growth restriction in the present pregnancy.
So let me just ask you a question. If you've done this kind of screening and you've understood that she's high risk for growth restriction or preeclampsia, that is one group that you are addressing by doing serial growth scans in the third trimester. Now, in India, there is a very frequent observation that women shift to their mother's house for delivery. So in the third trimester, there would be a lot of shifting of antenatal care. So if there is a lady who comes and meets a doctor in Chennai or Bangalore for the first time at 30 weeks, and she's carrying some of her reports, she's met different doctors at different places in her previous city, and nothing was told to her. So mother comes and says everything is okay so far. Would you consider that as an indication to do a growth scan at that point, or would you consider her as low risk and leave it and see her only at 36 weeks?
I would like to do a growth scan, but along with it, a detailed clinical examination would also help me determine the urgency of it, probably. Like if the symphysia fundal height corresponds, I would be probably less worried. But if I don't have any reports in hand, of course, I would want to have a scan. So.
So that's one way of looking at it. And that's why I'm saying that let's be open to this idea of doing a growth scan, because see, there are two opinions that have come there. One was this question, and Dr. Meena Mahalingam has said an earlier scan at 32 weeks and a later scan at 36 weeks. So I don't know whether we can do an audience poll here, but I think that's a very rational way of moving forward in today's day and age, because why wait till 36 weeks if you can detect something at 32 weeks? For the number of things that we spend money on, the cost of not doing a scan at 32 weeks will sometimes be more than the cost of doing a scan at 32 weeks. So I would agree to that concept of doing two scans, one at 32 weeks and one at 36 weeks, for the simple reason that your definition of early and late growth restriction changes with that watershed point of 32 weeks.
32 weeks,
So unless you've done one at that point and proved that there is no early onset growth restriction, then you're only left with the problems of late onset later on, and you can then classify your clinical care much better. So and the other advantage of doing a scan at 32 weeks would also be that you get much more scope to evaluate the anatomy and things beyond the 32 weeks. So let's come to Manisha. Given the idea that low risk people can be seen directly at 36 weeks, and there is so much to be seen, what would be your criteria of offering that growth scan? When would you want to do that growth scan if you just had a choice in any so-called low risk woman?
Ma'am, it's better we do because the visualization is very, very important. Rather than just giving a growth, it is important that we, and at least basic things have to be visualized in the fetus, like the head. We look into the four-chamber heart, and it's very, very difficult for at 36 weeks we anticipate a baby to be to get a four-chamber view or an outflow tracks that easily. So the growth scan with an anatomical check, it is important that we have to do a scan at 32 weeks.
Okay,
Not
so
on-
if you have a patient whom you have already seen, so she's been following with you, you've done the first trimester scan, you've done the mid trimester scan, and the chances of you finding something are extremely remote now. Your screening tests have been normal. So would you take that extra initiative and say that, oh, this one doesn't need a scan, I can see her at 36 weeks? Is that a reasonable approach?
This is not because of the concept of the evolving anomalies. So we can never say at any point that the scan is normal. Though we explain patient at this point that scan is normal. So the next
Even
scan,
if you have done, I mean, even if that scan has been done in Mediscan for that matter,
yes,
even then,
we will repeat the scan again at 32 weeks. So every time we see, we follow that basic checklist where we also look into the four chamber inflows. Whatever that is your guidelines, we do follow that checklist now.
so now the obstetricians are confused. They thought that once you see, there can be no other abnormality that we'll see later on.
That's
So
why I
how do you
emphasized on the
counsel your
evolving.
patients, and what is the best time to counsel a patient for a growth scan?
After the anomaly scan, we start our growth scan from 28 weeks, ma'am. 28 weeks, and we go ahead at 32 if required. If the growth is normal, then the obstetricians, usually the consultant decide they also want a final check on the baby's estimated fetal weight. They go ahead even at 36 weeks.
Okay, but you start counseling the patients at around the anomaly scan for the growth scan. And that is an important point because when we finish one fetal assessment, a part of that responsibility is to explain to the patient what are the findings that have been seen in this particular session, and also the fact that the pregnancy is an evolving condition, fetal growth is an evolving condition, even fetal anatomy is an evolving condition, and therefore we should have a follow-up. So once we do a mid-trimester assessment in a so-called low-risk woman, there is a very difficult definition of a low-risk woman. It's very, very difficult to describe it in obstetrics. So here we need to take a call about the cost of doing a test and the cost of not doing a test. So as obstetricians, as fetal medicine people, let us understand that what is it that is our ultimate aim. The ultimate aim is to have a healthy baby and a mother who will be going home without unexpected complications. So the advantage of looking at the mother and the fetus both in a combined manner in the third trimester are so many that there is very little justification not to do at least 2 third trimester scans. Now, when to time those scans is a bit of a, I would not say Vivaadham, but it is like a strategy which has to be made between the obstetrician and the fetal medicine team right in the course of the pregnancy. Because suppose you have a woman who's undergone first trimester screening, second trimester assessment of the fetus, and everything has been okay so far, then maybe you can call her back at around 32 weeks for the first growth scan and then around 36 weeks for the second growth scan, because you only showed how important that 36 to 37 weeks assessment is. And it's so much useful to just see the baby before you're actually taking it out, so that anything that has, evolved in that much period is something that you know. You may not be able to change a lot of things in the third trimester, but warning is forearming. So that gives you that little bit of a reason to intervene early. For example, you see just a slight discrepancy in the chambers of the four chambers of the heart, and that tells you that there might be an evolving coarctation, and with all your good intentions you've seen the heart before that, but now this is possible. And that awareness is so important because this will ensure you will get a neonatal echo done and you will intervene before that coarctation actually becomes dangerous for the baby. So in some of these conditions, just the awareness that there could be a problem helps in mitigating the final problems. Again, you see bowel dilatation, or you see some kind of changes in the abdomen, or some things which were not seen before. Rather than worrying about the patient getting back to us and saying, why didn't you see this before? It is important that we understand what is going on, give them an explanation, and plan for a good perinatal outcome, because that is when the patient will be thankful to us. If we don't see anything and just deliver, it's like prematurity, isn't it? You just deliver the baby and give it off to the neonatology, it's their headache. But ultimately, you're not changing the perinatal outcome. So the third trimester is the time when all of us have to stop thinking as only obstetrics and only fetal medicine, but have to think as a complete perinatal outcome for that family. And therefore, any assessment in the third trimester helps. While we have all concentrated on singleton pregnancies, what about twin pregnancies? Vaishnavi?
Twins, ma'am, by default would become high risk. So we will require a more frequent surveillance, no doubt about that. So
And
I
there
do
is a
agree before.
protocol, there is a set
Yes,
protocol
ma'am.
for monochorionics every
And
2 weeks and for
dichorionic.
dichorionics every 4 weeks.
Yes.
So if they are twins or multiple pregnancies, then of course we have a set protocol for them. If they are singletons and they have any kind of risk factors for growth, then anyway we do a 4 weekly checkup for them. But if there are no risk factors and you've had a good screening and anomaly assessment and everything, then probably 32 and 36 weeks. If you've never seen this woman before, it is very prudent to do a third trimester assessment as soon as. So all obstetricians who are encountering women who come for just for delivery, so they may say I was in Bangalore, they may say I was in Chennai, they may say I was in Hyderabad, but it doesn't matter. For your own safety, when you accept somebody, get a thorough checkup done, because that security is yours. So if you don't check at that point and you find something later on, then that becomes a problem. So one way of mitigating this would be that whoever does the scan wherever should give a detailed report and a detailed pictures and everything, so that if I see that report, suppose somebody is coming to Hyderabad and has a scan yesterday in BFMC, then there is no reason for them to have another scan in the next 2 or 3 or 4 weeks, because the standardization is so good. Similarly with Mediscan. So all these youngsters who are coming out of these organizations and going and working, I think you should maintain the protocols that you've learned in your respective organizations and continue to disseminate that good work, so that everywhere that standardized protocol of scanning is continued. So I'll let you both have the final. There's one more question, I think. Congenital diaphragmatic hernia can be missed. Yes. So it can be missed. So Monisha, suppose you'd done the last scan and looked for everything and you said everything was okay, but the child was born with a diaphragmatic hernia. How would you explain that to the family and to the obstetrician? Unmute yourself, please. Yeah.
We take all efforts to see both the diaphragm in SAG as well as in the coronal. And still, the defect is very small that we are not able to identify at that particular point. And it can be an evolving condition even at 36 weeks, 30 more beyond 36 weeks. So that is one thing. Yes.
Yeah, small or even large, because sometimes it can be a sliding kind of diaphragmatic hernia, where you don't actually see the defect in the diaphragm. You mostly see the effects of that defect, where there is a transposition of structures from the abdomen into the thorax. So maybe because it was a sliding variety at the time of your scan, it was not actually transposed, and you didn't see the change in the mediastinum, and therefore you did not comment on it. So that is very much possible. Yes, anything can be missed. If you have made an honest attempt to see everything, documented everything, even documented your limitations of where you had a problem to see things, then that is okay. That even the patient will understand that you were not casual about it. However, if you've done things in a hurry, you've not spoken to the patient, you've not even documented what, so many times, even if you don't document it on paper, if you have actually done the effort, talked to the patient, explained to her the difficulty while scanning, I don't think many patients will be that unreasonable to still get back to you on that. But yes, correctly, you should communicate and document the communication. However, if you have done it, that is more important. So you having seen it properly with an intention of doing an extensive third trimester scan is very important. And while you are scanning, talk to the patient. I mean, I learned a lot from Dr. Pratima in this way, that when you are talking, you are conveying a lot of information to the patient at that time, and that establishes a level of communication where the patient starts trusting you that you are making an effort in seeing whatever you can see. So, any other questions from the audience per se, or Dr. Karpam or Vijaya Madam, any comments you have to give?
Chitmayi, our main problem is telling the patient to come for frequent scans. Usually we say a dating scan, then a NT scan, and then a anomaly scan. After that, one more scan between 32 to 34 weeks for growth scan. Need be at the end to assess the weight. But the point, about 15% of the anomalies can be detected at cardiovascular. I mean, at 36 weeks is a real surprise for us. So when should we actually do the scan if the everything is normal, whether it is 32, 34, or 36? Give only one choice.
So, madam, we have to tell the patient that, the only thing that is changing in this pregnancy dramatically is the fetus. When you start the pregnancy, it is like a small dot there. Gradually, it becomes like a structure, and then things keep evolving. And the whole purpose of this pregnancy is the fetus. So, when the antenatal guidelines were made or protocols were made at that time, probably the availability of ultrasounds was very limited, and the accessibility of ultrasound was very limited. The ability for people to do detailed scans was very limited. As things have changed, today you have the advantage of getting the fetus checked at a frequent intervals and checking up everything. So I think obstetricians have to lap up this opportunity where, why should you go in blind? You should know what you're going to encounter. So ask more of your scan people, but get the scans done at least at 4 to 6 weeks interval in the third trimester, because the third trimester is a very dynamic trimester from both the maternal and fetal perspective. First trimester and second trimester is dynamic for the fetus, but third trimester is dynamic for both the mother and the fetus. So if there is a sudden change in the amount of the appearance of the placenta, the Dopplers, or anything for that matter, if there is a risk like she pointed out, Manisha pointed out regarding adherent placenta, all these things will really empower you to handle your ability, your management of labor and cesarean, whatever, at that point. I think I can see Indrani madam there. Ma'am, your comments please.
Actually, it has been a very interesting discussion, because this third trimester can definitely I think if it is otherwise no risk factor, once you have to do means, I would say it is rather around 32 to 34 weeks. Because at that time you can see reasonably the internal anatomy as well, and you can look at the growth trend. So, I mean, really after 34 weeks, late flattening or something going to happen is very, very less. At that time, it will give indication if there is any late FGR or how the Dopplers are. That is for the timing. As far as the diaphragmatic hernia is concerned, see, actually in later weeks all, doing the sagittal section to look at the diaphragm, it is just not possible. First indicator is you may see some mediastinal shift. Second is not seeing the contents. Like normally you should see the bowel inside the tummy. There are times when you find altered shape of the stomach. The stomach is trying to come down and dip. And you will find that because the herniation of the small bowel into the chest. So that will be rather a clue. That is, you have to see the structures which you ought to see in that place. So that only will give us a clue. And in spite of doing even at late, I've had one patient who had a target scan and growth scan. Those images were reviewed, were good. But fortunately, the child presented with diaphragmatic hernia. But most of the times, they do not have any immediate neonatal distress because the lungs are reasonably developed. They rather present as some kind of respiratory difficulty a little later, like at the end of 24 hours or 36 hours, which is understandable, and that has to be, as you rightly said, documenting. If you have one growth scan also where you find the abdomen is good and there is no mediastinal shift, if you see bowel loops in the abdomen and there is no mediastinal shift, that tells you that it has come up later. Most of the time, it's a small bowel containing diaphragmatic hernia rather than the liver or stomach going up.
Thank you, ma'am. Thank you so much for these inputs. And that's a very important point that you've highlighted, because everybody will feel once the scan is done, we should not have anything. So that is never like a 100% guarantee there, but the effort to do the scan is more important. Dr. Jayaprada, you wanted to ask something?
Yeah.
You
Dr.
can unmute
Jayaprada?
yourself and ask, please. Dr. Jayaprada?
Dr. Jayaprada? She had raised her hand.
Yeah, she had raised her hand.
Yeah, yeah.
But so any other questions, or do we still have to debate whether it should be only growth or beyond growth?
See, the topic came up only because the focus was mainly on growth and a lot of anomalies or other things. Even sometimes, when you have a sensitized pregnancy, RH incompatibility, you are going to check the MCA PSV Doppler. And a lot of times, when there is a sensitization and, the MCA PSV Doppler is abnormal, and if in case, whether it's in, needing intrauterine transfusion, I think all these things are third trimester. Definitely, we need to, as Madam says, it's very, very important to look at each and every detail and then document it. So
And
that is the
also
only thing.
not get carried away with the pre-existing factors. Like you
Yeah,
raised this issue
exactly.
with MCA Doppler. So
Yeah.
sometimes what will happen is you will concentrate so much on that MCA Doppler part of it
Correct,
that
correct.
you might miss that there was hydronephrosis or there was
Yeah,
bowel
I agree.
dilatation, because you get so excited with the like pre-existing risk
Yes, correct.
factor
And I always,
that everything else.
so this checklist component, this checklist concept is actually very, very good, because whether you do a scan also, okay, from the, like how we are clinically allowed to, we're clinically tuned to examine the mother from head to foot. We don't just say up, we just see the abdomen directly. So examine from head to foot for everything. So similarly for the fetus also, I believe that, we also have to see from head to foot, and also the environment. The placenta, the liquor, the cord, and everything, that is, I mean, that this checklist, the checklist component actually, the concept really helps in.
Okay, now let me ask an interesting question to the obstetrician. So, Dr. Jayanti, can you please mute yourself,
Can
please?
please mute yourself, Dr. Jayanti Nilavati? Jayanti
Can
madam?
somebody mute her?
Okay, I just muted her, yeah.
Yeah. So, no, one thing is we'll try and see everything in the third trimester. Indrani ma'am, please like give us this opinion. Suppose we don't see everything and we can't see everything. So we write this that, everything cannot be detected and limbs could not be assessed. So what is the obstetrician's response to this kind of writing? And Indrani ma'am, after they respond, please tell us what should we do
Yeah.
finally.
No,
Yeah.
as an observation, I will respond first. Okay. See, I always tell, scan is just a shadow. So, like whether it's an ultrasound or an MRI or a CT or whatever, you just are trying to interpret the internal anatomy or the pathology by just looking at a shadow. So that shadow can only give us certain details. It cannot give you 100% details of everything. That the patient, the couple have to understand, and the family have to understand. So what we are looking at is, like, we are looking at major problems, lethal problems, and most of the things, I every time I counsel a patient, I tell them scans can only diagnose 60 to 70% of problems, and there are a lot of problems which are evolving, and there are a lot of problems which can come up in the postnatal period. So most of the lethal ones, the life-threatening ones, which will cause failure to thrive, even then there are problems like inborn aneurysm, metabolism, which we really do everything fine and everything is normal, and still the baby can have problems in the neonatal period. So that is how we have to counsel them whenever it comes to talking to them about the accuracy of the scan or the sensitivity of the scan in diagnosing. Everything is pakka with the baby fetus.
Indrani ma'am, what should we do? Should we write or not write?
With age and then with changing trends in the population, maybe Karpagambal is telling right. No, we can, to the best of their ability, we can say. But sometimes the patients are very, that is because of the attitude and the mental aspect of the couple. There are families, however, whatever you speak, whatever you tell, no, they will not be satisfied. They will have some kind of dissatisfaction and always worry whether because I find nowadays these pregnant women are not at all cheerful. I think I am responsible for. I don't think 20 years before pregnant women were so worried and anxious. And also, as clinicians, one is documenting. See, at
Correct.
32 weeks, when I'm doing a growth scan, if I have a good visibility, I will say the internal anatomy to the extent visualized appeared normal, whatever we need to say. And as you said, you just have to tell the patient that, and at the same time, no, I see some reports, one upper limb could not be visualized. That puts the patient, see, if I were a patient, I will think that my baby's limb has suddenly disappeared. So instead of that, we would say if you're doing a growth scan at 32 weeks or like that, if you can see 3 segments of all 4 limbs, if that is possible at around 28 weeks. 32 weeks also it becomes. So we say detailed limb survey is not feasible. So whatever we have done, you give that in the report. Rest of it, we accept that it has been looked into on the target scan. So that would be a better idea instead of saying one upper limb could not be visualized and not putting them to distress unnecessarily towards the end of the pregnancy. So to the visualized extent, sometimes if the visibility is not good, you please tell that this much only is visible. I'm trying to look at the head. I'm trying to look at the lateral ventricle and the sulcation as well as cortical cells and all. Yeah, everything, most of the thing we can see in axial scans if we are doing properly. Sometimes in the posterior fossa wouldn't pop up nicely. So if I've seen only the BPD plane and the lateral ventricle plane, structures are normal. That tells you have
You made an
visualized
attempt and
only.
you've tried to
Yeah.
see it.
What you have seen, you put it. Similarly, 4-chamber, nicely you can see filling. And if LVOT, RVOT like this separately, we may not be able to visualize. So you say arches. Because once you see filling of the arches, that tells that the flow is, the ventricle is pumping. And then the vessels are also looking in the color, like in the first trimester, like you look in inflows and the arches in color. Similarly, in third trimester also, looking at the filling optimal, you have to do little image optimization so that you see good filling of the 4 chambers. And same way you would see the arches. That means it's filling well, and you are not going to get suddenly some major fallow at third trimester.
So I think, thank you, ma'am. What Dr. Indrani ma'am has brought these points out, and all the obstetricians who are listening also will understand why is she able to say so many things or put the point across through so many angles, because she understands fetal anatomy, she understands fetal physiology, and she spent so much of her lifetime just looking at fetuses. So the person who does that fetal evaluation has to be somebody dedicated to that purpose. So they have to get trained adequately, they have to work with a set protocol, they have to get updated, they have to follow the regular principles. And once you establish this system of care for the fetus, then there is no way that patients will feel left out or you will make major problems, because the principle of medicine is do no harm. So you do whatever is possible and avoid doing any harm. Obstetrics is not just about delivering the baby. Obstetrics is about taking care of the entire antenatal period. So maternal medicine is important, and the purpose of pregnancy is having a healthy baby. So fetal medicine is also important. So it is time that we work together as a team, and instead of wondering how many scans, we should know what all I need to see. So at this stage, I need to ensure that the anatomy of the baby is normal. At this stage, I need to ensure that the growth of the baby is normal. At this stage, I need to ensure that maternal environment inside is fine for the growth and the nurturing of the baby. And finally, at the time of labor, I need to also understand everything is okay for me to plan delivery. And with the advent of intrapartum ultrasound, I don't think you can get rid of the ultrasound or the ultrasonologist if you want good outcome in obstetrics, because why you should use us. I mean, when there is an possibility
Yeah,
of seeing. Why do you want to go in blind? So if it is a placenta previous cesarean section, I would want to be in
Intrapatam
that
ultrasound.
theater with you with the scan machine to tell you
correct, absolutely.
where to do things. If
Things,
it is
sure.
an even in the labor room, I think all these fetal medicine people also have to change their thought process that you didn't take fetal medicine to avoid emergencies. You have to become useful to the obstetrician even at the time of delivery and post delivery, and then we can build up a good, that 2026 level obstetric service for the best outcomes for the mother and the fetus. So thank you so much. I think it's been a very nice session.
Thank
Any
you.
other
Sir is
words
there. I
from
think
you?
sir is there. Sir, Suresh
Oh,
sir,
really?
any inputs
Sir,
from you, sir? Suresh sir is there. I saw Suresh sir
absolutely.
name also there.
I'm here. I'm here.
Hello,
Yes, sir.
sir. Good
Good
evening,
evening,
sir.
sir.
Excellent session.
Good evening, sir.
Excellent session. Good evening.
Evening, sir.
Excellent session. Very nice. Very well done. Both presenters were absolutely top class.
Thank you, sir.
It's a world class session we had today. Very beautifully and succinctly done.
Thank you so much, sir.
Every point very clear. Each one was they drew the boundary of what they needed to, and they were very clear in their thought process. So I'm very happy that the next generation has gone up in a very come up in a very nice way. And there are some
Thank you, sir.
nice mentors. Pratima is doing a fantastic job. She's churning out people in every place in India. A lot of training centers are churning out people for the next generation. So the future of pregnancy is in safe hands. So good thing for all of you.
Thank you, sir. Actually, we all look at as if there are what we I would like to tell as an obstetrician is no. There are times where the fetus actually gives us some clues that I'm well, I'm not well. So please pick up those clues. So that is what I always tell, even when I registers. See, you have a CTG in hand. You are monitoring a CTG. When there is unprovoked deceleration, yes, the fetus is telling that I am not doing well. What is the problem? This intrapartum, physiological monitoring of CTG, we have come up. Even in monitoring of CTG, we have come up a long way. So those old guidelines are taken up by this intrapartum, physiological monitoring of CTG. So we interpret in the clinical aspect. And when the fetus is giving some clues, when whether it is FGR or oligohydramnios or a placental problem, everything, just pick up those clues and just salvage the baby, because we have come a long way in terms of neonatal care also. So that is the reason why even with present obstetrics, fetal medicine, and neonatal care, I think we are here to focus and bring down our perinatal mortality to really very, very low levels at this generation.
Thank you so much.
And also, our neonatologists are also helping us, sir.
Yeah.
Recently,
Very much.
Dr. Srinivasan sir tells us about a fetal assessment tool. In our government sectors, we go with the FAT, fetal assessment tools, sir. So they are also coming and checking everything. So it is a multidisciplinary input from our side. So really helpful from the sonologist team as well.
Yes.
Really, we are learning a lot.
So even he recently had a baby with fetal hemorrhage. Like suddenly the baby, everything was fine. Suddenly the CTG looked very. So the NICU was prepared. In case the baby needed an exchange transfusion, it's a term baby. So all those things, the NICU people are also preparing themselves with all the necessary treatment modalities. And I think here is a time where we just have to take care of the obstetric fetal medicine and neonatal medicine together, and salvage all our babies. And our take-home baby rate should be like 100%.
Thank you. Chinmay is holding us for a longer time. She has to go, I think.
Oh, sure. Sorry. Anyway, I think it's 6:35. We'll just thank you. Thank you so much, the speakers, Dr. Vaishnavi, Dr. Monisha, and Dr. Chinmay. Thank you. It was a very enlightening session. We just want to keep it crisp and short and crisp, and with all salient points. And all the points are very well taken. Thank you so much for being there. And thank you, Suresh sir, Indrani madam, for your inputs. And I think Pratima madam left, I think. So, Vijaya madam, Meena, for the opportunity. I really enjoy doing these sessions. When Vijay madam was a president, I was doing Aksharam, and now with Sampath madam, I'm doing Vivaadham. So we are touching all aspects of obstetrics and gynecology, and this time we had fetal medicine. Thank you so much for giving me this
And
opportunity.
the important thing is all of you who are Foxians here should have ensured that you've paid your annual registrations and you all are, registered voters for this year, because
yes.
even
So
if,
we are
like, just like the documentation of third trimester scan, even if your intent is there to help and you are not registered voters, you will not be able to vote
we
at
are
that point. So in January, all of you should ensure, and the Oxy members also should make sure that everybody has renewed their Foxy membership, because only when you are registered before, I think before March, if I'm not wrong, then
March.
your
we are
vote will be
eligible.
things. And you can always check your membership number by going on to the Foxy website also. There's that unique number. So please do it, because if we want to help madam, we have to do it properly right from the beginning.
Yes, we're all here to support Madam Sampath Kumari Madam, and we just want to see her as the president of Foxy soon.
Thank you everyone.
Thank you everyone for
Thank
joining.
you
Happy.
also Sri Events for having given the wonderful platform, extending the platform as well. Thank you so much.
Thank you.
Thank you.
And
Thank you everyone.
I
Whichever
once
you are
again
happy.
request everyone to vote for Sampath Kumari Madam contesting for President Foxy between August 1 to 10. Thank you so much.
Thank you. Thank you.
Thank you.
Thank you everyone.
Thank you, ma'am.
Bye.
Bye.
Any